guys for having me. It's been an incredible visit out here. You guys are doing the program, and it's been an honor talking with everyone. So today I'm going to talk about moderate and severe TBI in the deployed setting and how it differs in terms of how we would typically manage it in a civilian setting, and kind of how we got to that point and the reasons for it, and some of the controversies behind it, because it's certainly different behind what we would typically be doing in the civilian setting. So, all right. Well, I have no disclosures other than I do a couple spine labs for my residents at Cooper. My usual DOD disclaimer, and that I am a unattached Philadelphia sports fan. Certainly not proud of who I become when I watch a Philadelphia team, so I do have to watch them largely in private. But those are my only permanent disclosures for you. So when we start off, I'll kind of start going through the evolution of how wartime neurosurgical care kind of evolved from World War I up through World War II to Vietnam and up to Iraq and Afghanistan, and how that differs from what's typically happening in civilian setting. And kind of a great segue from the cranioplasty complication is how we're reconstructing some of these issues and some of the challenges that we've faced with that. And then I'm going to segue that into some of the ongoing issues that the military has with trauma readiness, kind of why the reason that I'm currently at Cooper. And then we'll finish it up. And in the picture, it's always funny how I think neurosurgery has, or at least military neurosurgery, tends to have a great relationship with kind of progressing things in the civilian sector. And one of the things that was brought back during Iraq and Afghanistan, you'll see here, is the Kempe incision for doing a big unilateral decompressive hemicraniectomy. And this was from back in around early 2000s that it was one of our, actually a pediatric nurse, Jonathan Martin, who started doing this. And that while it's great in terms of the size of decompression it can get, it certainly created some issues for trying to reconstruct that down the road. But it's certainly an option, and it was actually just written up by Dr. Chestnut in his group out at Washington, that they're actually using the Kempe incision more often in terms of for people who have anterior skull base trauma that may not be leaking, and that they want to be able to get a big decompression but not burn bridges down the road by using the reverse questioning mark if they do end up having to do some sinus work stuff down the road. So, but I can assure you guys that I, by and large, do not pin for my decompressive hemicraniectomies, and that I am certainly not advocating for routine use of the Kempe incision. Okay. Oh. We're gonna go low. Okay. All right. Check my voice here a little bit. All right, so going through some of the evolution of wartime neurosurgical care, that I think neurosurgery does have a unique history in that even at the highest levels of neurosurgery, there's always been a really proud history of military service. And this goes all the way back to World War I, when Lieutenant Colonel Harvey Cushing served his time. And this even started before his actual formal military service. So in around January, February of 1915, when wars first started breaking out, there was a group of residents, American residents, who were training in Paris, who noted a need for medical care in the city because everything was being pushed forward to the forward lines. So they put a call back to academic medical centers, and you can imagine that at the time, if you can imagine having your training interrupted or being asked to go cover a war hospital in World War I. But Case Western was actually the first hospital to go out and staff it for 3 months, and then Cushing and Harvard followed in April of 1915 before any American involvement. So this was purely voluntary on his behalf. So when he first got out there in 1915, he started off in the actual city of Paris, a collaboration between the government and the American ambassador. They said they converted a school into a makeshift field hospital. And while he was taking care of some essentially routine wounds for the day there, during that time, you see that he did get deployed more forward to some of the British field hospitals. And this is where you start to see some of where Cushing diverged from what was going on during the time, and that he really developed some keen interests
more so in wound care, that you think about the paradigm of the day for people with penetrating head injuries at that point was essentially um, delayed primary closure after a couple washouts. Sometimes they didn't even close it, and that they would let it granulate over with, as you can imagine, incredibly high infection rates. There was very little in the way of actual fragment retrieval or debridement, which in the pre-antibiotic era, you can imagine would end up being a big problem with that these were dirty, contaminated wounds from trench warfare. And by and large, that they weren't being addressed for about, anywhere from like 5 to 7 days before they even reached medical care at that point. So Cushing being Cushing, he essentially developed a really keen interest that when he was going to be coming back, that he started to really advocate for the upfront primary closure of these wounds, which is something that we see carried over to currently. While we're certainly not going after all fragments, you can see that in his time that it would make perfect sense that you would have these low velocity contaminated wounds that trying to get out as many of them as possible would make complete sense. So he actually, when he was with the British teams, what he noted and started using was that they had this long, thin nail that they would put a magnet to it, and that they would literally go through the bullet tract and turn on the magnet as it would reach it, and then be able to retrieve as many of the fragments with it. And they weren't using that for head wounds, but he decided to start doing as such, and started doing that during his first time there. And the other things that you would see is that he developed a really keen interest that, and it's always interesting how the problems of over 100 years ago still persist today, that he had a very keen observation that we were not ready for the types of wounds that we were going to be seeing, and that he was concerned for medical readiness, that the American medical community was not ready for what they were going to be seeing if and when we eventually got involved in World War I. So when he eventually came back a couple months later, he was very active in publishing his experience and trying to get word out to the medical community about what was essentially coming our way if and when we got involved. And there was something called the Battle of Boston Common, in that he was, in order to try and raise awareness between the medical and lay community, he actually wanted to set up a makeshift field hospital in Boston Common and have basically simulated wounds to be able to try and tell people what we were getting into. That was, he was fought at every step and eventually lost, but it was nonetheless what he referred to as the Battle of Boston Common, and still something that we see going on today that I'll get to a little later. And then he returned once the formal American involvement started in May 1917 until the war effectively finished up. And some of the innovations that you really see during this time from Cushing is that the British neurosurgeons, that for penetrating head injuries, they weren't even turning a small cranie. They were completely working through the defect in and of itself. Very limited amount of brain debridement, and very little use of antiseptics, with, obviously high infection rates, high mortality rates. In the hands of the Brits, it was anywhere from, it's generally about 60% mortality. So Cushing's innovation was to be able to actually turn a craniotomy around these things, which was, it seems so intuitive for what we do now, and that we take it to a whole other extreme, but at that time was a complete innovation. That he was very aggressive in debriding that non-viable, just kind of pulp, nasty looking brain around that point, which I think that in the inability at that time to be able to really safely do a full decompressive hemicraniectomy, that being able to debride that non-viable brain is probably what gave some of these people a fighting chance, is that by doing essentially what we would consider either doing like a strokeectomy or a contusionectomy is what he was getting to. He was aggressive about his use of antiseptics through the actual bullet tract, that he would instill antiseptics through it. And again, the upfront primary closure of those wounds. So in Cushing's hands during World War I, he was widely accused of being the slowest neurosurgeon, and almost criticized during his time. That generally people were able to get through around 15 to 20 cases a day. During World War I, Cushing was averaging around 8 to 10 cases, but his mortality rates were much lower. So his mortality rates were around 30% in his hands. So, and you still see a fair amount of this that translates to what we do today. And in World War II, we get to Major Donald Maxson. He interrupted his training at Brigham and Women's in pediatric neurosurgery, and he was the main American neurosurgeon who you would see that his tenets that he widely published and popularized during that era. And that what you see is that he prioritized a first recognition amongst neurosurgeons that we tend not to come in until, if you're looking at the ATLS algorithm, that we tend not to come in until the D part of it, initial recognition of ATLS algorithms and where we come into that. At this point, we were in the antimicrobial era. So you see his paradigm change to having an aggressive bony decompression, where you're probably seeing the first real decompressive hemicraniectomies of the time. Limited debridement in an effort to try and preserve it, or preserve as much neurologic function as possible. Not as much these days, but he was very much into watertight dural closure, which made sense at the time, and also delayed cranial reconstruction. So when we go to Vietnam, that's also, if you go through, there's also, in military neurosurgery, we're also kind of prone to, there's different people in at different times. So if you look in the Korean War, there's very little, if anything, published regarding neurosurgery in the Korean War. It's almost a complete gap in the literature. So now in the Vietnam conflict, William Hammond was the chief of neurosurgery at Walter Reed during that time. And he went back to more of a Cushing mantra with aggressive debridement, retrieval of fragments that he truly felt was necessarily the right thing to do. But when he went back and compared his outcomes were actually worse. So now when we get to Iraq and Afghanistan, that there's essentially an early experience and the late experience. And if you look at case fatality rates, essentially in any conflict, that we're always very proud to say that as our case fatality rates go down exponentially with each conflict, and that at this point, if you make it to an American military treatment facility in the war setting, that your chances of survival are around 97, 98%. But at the beginning of each conflict, you always see this little uptick in case fatality rates, and that's largely due to forgetting lessons learned from prior conflicts. So we certainly saw this as well with Iraq and Afghanistan, and we'll kind of get into some of the reasons for it. But individuals like Rocco Amanda and Randy Bell were very emphatic in popularizing our current management paradigm, which is by and large aggressive unilateral decompressive hemicraniectomy, limited debridement, only retrieving fragments that are easily accessible to ourselves. And while I don't think we're necessarily doing anything different with regards to how we're managing them from a neurocritical care standpoint, I'd probably more so put it in the line of pushing for that. If you make it to the hospital, you're making it home. And that translates into an emphasis on survival and giving these people a chance up for a full year or two to try and allow them the best chance to recover. And also as well, our evaluation and screening and evaluation for traumatic cerebrovascular injury, whether that be doing a lot of diagnostic angiograms for people with penetrating head injuries for pseudoaneurysms, or the probably more popular was the recognition of post-traumatic vasospasm in blunt head injuries, more so from the blast over pressure rate and the treatment of that. So I'm not going to bore you guys with the details because everyone else knows how we would typically get to this point, that if we're dealing with essentially a Marshall III closed head injury in the civilian setting, that we're going to, if we're in a routine civilian hospital, that we're going to be managing this in a graded incremental fashion in line with our Brain Trauma Foundation guidelines, and potentially progressing to considering a decompressive hemicraniectomy if midline shift, those contusions were to blossom in a secondary manner, or before considering other tertiary means. So now this case could just as easily be a 32-year-old who was thrown 15, 20 feet from a IED blast with no other apparent injuries. And then we get into how does being in an employed setting make this case a little bit different in terms of how you would manage it. So this is essentially what you have. So if you're deployed, you're going to be at essentially a receiving hospital. You're right off the back runway of Baghdad. It's a series of tents over a enclosed blast structure. There is a flock of pigeons that lives underneath basically between your blast walls and the tents. And you have air conditioning, but you have to make a choice that if you have air conditioning, that you're going to have pigeon feathers coming in through because there's no HEPA filters out there. Or you can either be working and operating in 115, 120 degree heat. So it's a choice that you got to make. You have a 10-bed ICU that's generally equipped to be able to hold people for anywhere from ideally only on the order of hours. You want to get people out of there within 24 hours, or else you're really going to be using up all of your resources there. And that you have a 16-slice ancient helical CT scanner that is actually across the street because there's two hospitals. You have the military hospital and you have a State Department hospital. And you have to actually wheel the patient from your hospital out in the wide open across to the State Department hospital to get a head CT and then wheel them back. And you have enough operative equipment to essentially do some basic cranial trauma work. You don't even want to consider doing any spine surgery unless you're dealing with a progressive incomplete spinal cord injury with something like an expanding hematoma or something like that that you can address without instrumentation with regards to spine surgery. And I booked on Uber. There's no way to get anywhere. You're stuck there. So when we started off in the war, we were essentially managing that. We would be managing that injury in the identical way that you would be either putting in a bolt or an EVD and managing them medically, without an acknowledgement of the fact that these people have to go through a 6 to 8 hour flight in which they can pressurize the cabin to around 5,000 feet at the most. If they try and pressurize it any lower, they really burn through their fuel, and then it ends up becoming more of a risk in terms of to the flight crew and the aircraft. So that's the most that they can pressurize the cabin to. And probably most importantly is that while you have critical care air transport teams that are staffed either by a ER physician or an ICU physician, their level of familiarity and ability to be able to troubleshoot a ventric or a bolt at 30,000 feet is pretty small. And early in the war, we had, it would be lying to say that we didn't have issues with people showing up with these high energy mechanisms that would show up, blossoming their injuries in flights, and showing up with potentially salvageable injuries, fixed dilated in a hospital in Germany, or if they had to bypass Germany for whatever reason, showing up at Walter Reed at that point. So at that juncture, it was essentially mandated that for people who have salvageable injuries, that the paradigm is going to be by and large a unilateral decompressive craniectomy with a contralateral ICP monitor placement, and the policies that we talked about before with regards to limited brain debridement, only retrieving fragments that are immediately within a centimeter of cortex that are available to you that you feel like you can safely get without jeopardizing major vasculature. And we started implementing that policy throughout the Iraq and Afghanistan theater.
Hey, Corey, was this all penetrating or just?
This is a mix of penetrating and head. So now when we wrote up our initial experience with this, what we started noting is that even though people with the worst injuries that from essentially initial GCS was a 3 to 5, that they were still achieving Glasgow outcome scores greater than or equal to 3, meaning that they were still at 1 to 2 year follow-up with proper family counseling. I think those are acceptable outcomes, and depending on what families are after, and that by and large, most of these families, if they can have meaningful interactions with their loved one, they're in it for the long haul. So now when we looked at people who were managed in this manner with regards to decompressive craniectomy, and we subclassified that, and again, just looking at our indications for doing it are essentially the same for what we would be doing here, with the exception of considering more so for people who come in with just a young tight brain. And so essentially your kind of Marshall 3 severe TBI picture, that they are going to get decompressed up front as opposed to a medical management paradigm. And so what we noted that with our data was that around 83% of them were a Glasgow outcome score of 4 or 5 at least at 1 year post-injury. So some other data that we were looking at as well was the time to decompression, and this generally helped us be able to stratify and try and prioritize where hospitals were located and in terms of how we get people to us and the pace of which we get people to us. And that essentially for a brain standpoint, our golden window was around 5 hours, that we found that for being able to evaluate and decompress them within 5 hours resulted in greatly decreased mortality rates. And where we get into some of these controversies is that this data is, while it certainly includes penetrating and blunt head injuries, that it's definitely different than what we're seeing from some of our main trials in terms of DECRA, which I put in the trial. I just wanted to put baby in the corner there since nobody likes DECRA. I just certainly don't like DECRA. But when you consider the results of Rescue ICP, considering that if we're having 83% of people who have a Glasgow outcome score of 4 or 5, granted we're comparing Glasgow outcome score to the extended Glasgow outcome score, but it's certainly a difference. And while it's tough to be able to compare the military and civilian population, the group at Shock Trauma was able to made an attempt at doing this. And what they looked at, looking at those with penetrating head injuries, is that we're certainly intervening on a lot more of them in terms of giving them a chance, and that there's a corresponding improvement in survival. Again, no big surprises there, nothing earth-shattering, but it just more so highlights the need to be able to try and compare and try and look at the reasons that why are the outcomes different between military and civilian populations with regards to aggressive management of severe TBI. And then when we also go through and look at for those with penetrating head injuries, again, when we go through and look at that, if you're be able to compare them for those who come in with salvageable head and salvageable GCS scores, that comparing the 2-year Glasgow outcome scores, that there's a clear difference in comparing the conglomerate of civilian settings versus military settings. And why is it different? I think it depends on whether you're looking at it from a glass half full empty or glass half full standpoint. That do we have better patients? We're certainly dealing with a young, healthy population that have the physiologic reserve to be able to recover from these injuries, and that they have complete unencumbered access to world-class neuro rehab for essentially the rest of their life after that these events happen. The glass half empty argument is, are we just decompressing a bunch of people who didn't need to be decompressed? And I think the truth is probably going to end up being somewhere in the middle. But I think that there's also a valid question here that, Rescue ICP, DECRA, and a lot of the civilian trials, no one's really truly addressed the role of primary versus secondary decompression. And I think that the military data is probably the closest thing to addressing the potential role of considering a primary decompressive hemicraniectomy for those with a Marshall 3 head injury in a young tight brain, as opposed to standard medical management and considering decompressive hemicraniectomy as a secondary measure. And again, I think we're not necessarily doing anything different from a neurocrit standpoint, other than acknowledging and basically acknowledging a commitment to survival and that giving these people a long-term chance. So now I'm going to segue into what I widely considered to be the Rodney Dangerfield of neurosurgery and cranioplasties, that for a procedure that has as insanely high of complication rates as it does not get the respect that it deserves. So in our hands, when we first started off, the infections were around 12%, and some of our biggest risk factors were when we started off in the war and we had a lot of issues before we were figuring out how to be able to protect soldiers from subfrontal injuries from IED blasts, that we had people with lots of paranasal sinus involvement and anterior skull basin involvement, and that when you had a lot of these people that were essentially completely missing their superior orbital rims and orbital roofs, that when we initially tried to reconstruct these people in a single stage, that our infection rates went way up because we were jeopardizing our already existing skull base repairs when it came down to. And another thing that we started noticing is that for people who that with a lot of these high velocity mechanism injuries, that the brain that didn't necessarily want to bounce back, that a lot of times you put that plate on and the brain does within 24 hours, just say it's amazing sometimes how that brain sucks right back up to it. Didn't necessarily happen all the time in our hands. And we started noticing that people who their brain was not sucking back up to the plates, that they were at risk for infection. And it wasn't uncommon for us who had a lot of dead space. So we established a protocol where that for people who had a lot of paranasal sinus involvement, that we would stage their reconstructions, and that we would start off by doing a split thickness calvarial autografting, where we would expose everything, harvest back, and then be able to split that on the back table, much like you would do for vault remodeling for a kiddo, and reconstruct the superior orbital rims with that as a first stage, but then heal from that, and then bring them back. And then at that point, depending on, by and large, all the bone goes into, if you had decompressive hemicraniectomy in Iraq or Afghanistan, your bone goes into garbage because it's already a contaminated environment. So then it comes down to dealer choice in terms of whether you're reconstructing with PEEK or titanium. So at that point, we were largely reconstructing with Tymesh at that time because we were very concerned about infection, and that we were more so concerned with biofilms being able to form on PEEK long-term in people who were at higher risk. So, and especially individuals who we were not necessarily concerned about having to re-image or necessarily get MRIs on long-term, we were erring towards Tymesh a fair amount. And with addressing the dead space, if we were considering that dead space was going to be an issue, and this was also before the era, now it's pretty common for me in my civilian practice that if I think that the brain's not going to bounce back and that we're not terribly concerned about cosmesis, that I'll do a lower profile. I'll bring the profile of the plate down by anywhere from sometimes up to 15-20%, just to be able to make have the brain have to do less work to be able to kind of re-expand to be able to fill that dead space. But in this time we were basically doing free muscle flaps, where we would basically harvest ALT and vastus lateralis, and then plugging that into STA and STD underneath so we would put that basically on top of an epidural, and to basically fill out the dead space, and then reconstruct over top of that to minimize our dead space.
That works.
Subjective, whether that was our plastic surgeons wanting to, wanting to do a lot of micro work. I can say we weren't hurting people, and they were fans of it. So now, when we just to summarize some of the primary stuff that we talked about, the outcomes are different between decompressive hemicraniectomy in the military and civilian population. And, it makes sense considering what we're dealing with and some of what the conditions are on the ground. And for post-traumatic reconstruction, especially when it starts involving paranasal sinuses, we tend to consider it as a staged procedure at that point, as we discussed. So now the challenge is tending to be that maintaining our trauma skills, that we have lower volume and continued deployments, because now that we're in a relative time of peace, a lot of us are sitting back at military hospitals with relatively low case volumes, taking care of healthy people that respond to conservative management. So this has been, again, it's not a new problem. That Cushing noted it in World War I. Desert Storm was essentially marred by the fact that the only reason that Desert Storm wasn't a much bigger issue was because of the fact that there was very little casualties, but our medical response was very, very disorganized and poor, especially from a neurosurgical standpoint. We didn't even have an up-to-date roster of neurosurgeons that were available to deploy. We actually inadvertently deployed a couple residents. No offense, but there was fourth and fifth year residents deploying to war zones as full functioning neurosurgeons in Desert Storm, essentially by accidents. And that when you fast forward to now, it's still there where you have a lot of general surgeons and trauma surgeons who all it takes is one or two to be able to go to U.S. News and World Report, and we end up with a lot of bad press. So when you look at the Army, we did a survey of Army neurosurgical treatment facilities looking at cranial trauma cases, and we've stratified that by their ACS trauma level. There's only one, while we tried to keep this anonymous, there's only one level 1 trauma center in the U.S. military, so it's no secret which hospital that I'm talking about here, which they only draw from around 10% of the city that they serve, and the rest goes to the other main center. And at that place, there's 10 neurosurgeons, and there was only 63 cranial trauma cases in the 2019 calendar year. So, and then when you look at the average total number of cases that neurosurgeons in the military are doing, in that year, granted, there was COVID that was going on, but there was other places where they were still managing to maintain volume at around 84 cases a year for active duty neurosurgeons during the 2019 calendar year. So obviously an issue, and it essentially became a congressionally mandated that as a result of a lot of this bad press that was coming out about this issue, that the military would establish military-civilian partnerships. So the AMCT3 program was essentially founded as part of that. It's called the Army Medical Civilian Trauma Team Training Program. It was established in 2018 as an ability to be able to put trauma-related subspecialists at busy urban trauma centers. So I was lucky enough to be the first neurosurgeon to be attached to it in 2018. And I essentially came on with the focus of neurotrauma and neurocrit, where I take the boots on ground staff for any emergency from Monday through Friday from 7 to 5. I take my fair share of call for the system on top of that. I do have a full complement of residents, and I round every day with the resident team on anything that's generally come in. And over around an 18-month period, I did around 201 cases. And I think the important number is that if the goal of the program is trauma readiness, and particular cranial trauma, that during my first stint before I left for my second deployment, that I did the same amount of trauma cranies on my own compared to the only level 1 trauma center within the military. And in terms of what does the hospital get out of it, the receiving hospitals, is that I'm free labor to them, and that's they get the bill $3.4 million for my services, of which I get my military salary. So again, we just compared those numbers, and again, if the military is about readiness, that's being able to, as Mike Tyson would say, everyone has a plan until you get punched in the face. But being able to get punched in the face as often as possible is probably the true path to trauma readiness. And being able to deal, whether it's a 32-year-old who took a fireworks mortar to the head on the 4th of July, or this was a 9-year-old who was playing in the woods with his father near a train track and was chopping down a tree and left an axe on the train track when a train started coming away, and ran away, but the axe flung up from the train when it hit it and lodged right into his left side there with a complex dura and brain exposed, depressed skull fracture and head injury. So some of the keys that we've noticed so far for being able to establish good civilian mil-civ partnerships is that there's got to be the right culture within the hospital itself, because at the end of the day, if people are there, financials can get involved in that. If you have people who are coming in with subspecialty focuses that are almost outside of what the realm of trauma, and that you have people who are paid off of, who have an RVU-based bonus structure, that the military guys are coming in and essentially taking away from their potential bonus structure, that there have been some of the AMCT3 sites where people have not been greeted as ceremoniously as they were at Cooper. And I think it also just comes down to matching the right person and skill set to the right partner sites. While I fit in great, my skill set as, in neurotrauma and neurocrit, fits in great at Cooper. If they were to put me at a Baltimore shock trauma or down at Miami and Ryder, where they already have, a couple different versions of me in existence, probably wouldn't be the same. So there's a couple of different things in the future. I know you guys have stuff that you're going, so I'll open it up to questions and leave you with pictures of my favorite people in my life. Thanks.
Wonderful. Thank you very much. Boy, this is really a very smart idea on Alfred's part, is that people need training, and if there are not traumas in war zones in the inner city.
Yeah.
So that's a good place to get training. Good point. The one thing I'm impressed with is that how much everything old is new again in this care. And I'm not sure who's right. It was Cushing right all along.
Yeah.
What do you think about that?
I think that if you look at what people were dealing with in the time that they were dealing with, I would say that Cushing was the close to having it completely right, leading up to the wars in Iraq and Afghanistan. And I think that I think the system that we were able to come up with, while it was certainly aggressive, it certainly afforded people the best protection to be able to make it back home in terms of what we're dealing with in Iraq and Afghanistan. But is that going to work for the next conflict? Honestly, probably not, because if you think about where we're going in the future, is that the big thing that we're worried about are near-peer conflicts, that we're not going to be in a fight with Iraq or Afghanistan where we have air superiority and that we can get people in and out at will. We're not going to have air superiority if we're in a fight with Russia, China, or North Korea. And prolonged field care is essentially going to be the next wave. And whether that's going to entail having to have neurosurgeons and serotoms and portable CT scanners as close to the action as possible, whether that entails having general surgeons who are being able to train to be able to do basic cranial trauma, which has happened before. It's certainly reported we even have a clinical practice guideline for general trauma surgeons on indications and reasons to perform cranial trauma procedures, and we train them for it before they deploy. But those are some of the things that we're worried about for the future.
I think the residents also need to understand that throughout history, the injuries will vary from conflict to conflict between high velocity penetrating bullet wounds of today and a large number of different situations of shrapnel, which you could see some of the magnet in World War I because of tremendous amount of shelling that place in World War I. Just trying to find low velocity hunks of metal from the shrapnel, which were parts of the engines.
I didn't mention it during my talk as well, but one of the things that I personally struggle with in my line of work is dealing with venous sinus injuries from a traumatic standpoint. And Cushing explicitly mentioned that as a frustration. He called them gutter wounds, and that by and large they were from people when they were poking their heads up above the trenches, and they had those crappy little tin helmets, and that they would go through. And yeah, that's again what's old is new, and dealing with penetrating injuries to the venous sinus. Yeah, they're still the bane of my existence, and I feel like I get it wrong as much as I get it right, and it's frustrating.
Thank you very much.
Yeah, no, thank you guys.
Great. Thank you.